Welcome back to the Now What podcast, a podcast focused on young adults, epilepsy, and the problems they face. I'm Karan.
And I'm Sophie, and we are advisors to the Cameron Boyce Foundation. If you haven't heard of us, TCBF honors the legacy of our best friend Cameron by aiming to cure epilepsy through funding research, education, and awareness campaigns, while still supporting causes that were important to Cameron.
As always, these amazing conversations wouldn't be possible without our phenomenal sponsor, UCB. Thank you, UCB. Each week, we're going to discuss an important topic related to epilepsy and young adults, and this week, we're covering epilepsy basics. This is a great episode to send to friends or loved ones who are looking to understand more about the disease.
So, with that being said, our guest this week is Dr. Lisa Bateman. Dr. Bateman is a professor of neurology and the director of the surgical epilepsy program at Cedars Sanai in Los Angeles. Dr. Bateman gives a really great overview of epilepsy, and Karan and I were saying that even though we've been doing this for 5 years now, even we learned stuff about epilepsy basics.
I can't tell you how much I took away from this episode.
Yeah, so even if you want a refresh for yourself, pick up some new facts or send it to your friend like Karan said. We hope you enjoy. Thanks for joining us.
Dr. Bateman, thank you so much for being on the Now What podcast. We're really excited to have you.
Thank you for having me.
And the spirit of talking about the basics of epilepsy, can we get the basics about you? Can we get your background and why you chose to pursue this field and focus on epilepsy?
Sure. So I'm a Canadian neurologist, epileptologist, treating mostly adults with epilepsy. I started out in this area. I was always fascinated with how things work, how the human body works, and specifically how the brain works. So studying neuroscience was always something that really attracted me. And when I was doing my undergraduate degree in human physiology at McGill University, I had the opportunity to work at the Montreal Neurological Institute, which many people will know as a very world-renowned epilepsy program, and had the opportunity to volunteer with a lot of their epilepsy patients who had been traveling from all over the world to try to receive their care. And just being able to spend time with these people, hear about the impact of their disease on their lives and the lengths that they were going through to try to seek treatment really left an impression on me. And as I studied further in medicine and in neurology, started to see that, the physiology of the brain, how epilepsy is just a big, the brain's physiology in action, so to speak. And it's also one of the fields in neurology where we can really make a big impact. There are multiple treatment options, from medications to surgical interventions and other things. And so it's really a field where we had so much to offer and really have an impact and change people's lives. And so that was a big attraction as well.
That's amazing. That's a great reason to get into it. I'm curious. We've obviously done quite a few of these episodes now, and we've learned about a lot of different nuances with epilepsy, but I'd love to kind of get an idea. Like in the simplest terms, can you kind of speak to what epilepsy is for the person who maybe doesn't really understand or know?
Sure. Epilepsy, the simplest definition is that it's a chronic brain condition that is characterized by the tendency to have what we call recurrent, so more than one, unprovoked, no reason for it, seizures. And, many people will also use a term seizure disorder because there's a bit of baggage that comes with the label epilepsy, and society, a lack of understanding and some stigma that comes with that word. But in essence, they're kind of interchangeable terms. Epilepsy can impact anyone at any age, and there are lots of different causes for epilepsy. In general, it impacts about 1 in 26 people over the course of their lifetime, so it's not an uncommon neurological disorder. There are currently 3 million adults in the United States and close to 500,000 children in this country living with epilepsy, and over 50 million people worldwide.
Wow.
And I'm curious to know, I think when we speak about epilepsy, at least as a society, we really try to simplify it and just go like, oh, it just means that someone has seizures and kind of filling in the blanks, they just assume that all seizures are the same. Can you speak to the different types of epilepsy that are out there and like how they might manifest and, how they kind of maybe appear in our day-to-day life in ways that we don't expect.
Sure. So everyone thinks of epilepsy, like you say, as one thing. Everyone knows the big seizure, the TV seizure, the Hollywood seizure, right? You black out, fall down, your body shakes, you bite your tongue, you get confused. That is one type of seizure, and it's a type of seizure that can be seen in a lot of different type of epilepsies, but it's not the only type of seizure. When we talk about seizures and epilepsies, we talk really about two big worlds. The first world is a group of seizures, what we call focal seizures, used to be called partial seizures. And those are seizures that start in one particular area of the brain. They may say isolated to that part of the brain, or they may spread to other areas, but the origin is in one particular place. And when you think about how might that type of seizure physically affect you, it really depends on what the area of the brain is where that seizure starts. So the seizure may start in the area of the brain that controls, for example, your sense of smell. So you may have an abnormal smell, or start in an area that controls your movement of your arm. So you may have twitching or shaking of your arm. So it's really, any sensation your brain can give you can be a manifestation of a seizure, just depending on where that starts. We divide the focal seizures into two main types. We call them now focal aware seizures, used to be called simple partial seizures. And those are seizures where people don't lose awareness. So they may have, again, some physical manifestation of the seizure, but they're still aware and able to interact with their environment. Mm. However, other types of focal seizures may impair awareness, and we used to call them complex partial seizures. And basically the complex part just means you lose contact with the environment. So people may, be inert, they may stare, they may be unresponsive. Sometimes they may kind of look like they're interacting, but there's a lot of automatic type of behavior. They may fidget with things, they may blink, they may smack their lips. They may kind of wander around a little bit in a daze and may say even simple words or seem to respond, but are still not quite there. And when you ask them after the event, they may have, impaired memory for the episode. When we talk about generalized seizures, on the other hand, those are seizures where both sides of the brain and large areas of the brain are involved straight from the beginning. So what we are talking about, the TV seizure, what we call a generalized tonic-clonic seizure, that's that type of seizure where both sides of the brain are involved at once. But there are other generalized seizure types that are not so dramatic. There are, for example, what we call absence seizures, where the person is simply absent for a few seconds, may kind of pause in conversation, stare, and then pick up a few seconds later as if, nothing had happened. There are tonic seizures that are generalized, where people may get stiffening, or clonic seizures where there's jerking, myoclonic seizures where they're also really brief types of jerking. So there are lots of different seizure types within that generalized umbrella.
That was a fantastic explanation of really getting. I mean, I know there's so much more nuance to it, obviously, but I think people don't understand focal seizures really at all. So many people don't know, and it's just good to kind of get an overview. So thank you. As far as treatment and seizure response, what are the current various types of medication for seizure control that are maybe most prominent at the moment?
Yeah. So the mainstay, as you said, of epilepsy treatment is anti-seizure medication. Essentially, the anti-seizure medications work in different proteins or systems in the brain that control how the electricity moves within the brain, because a seizure, is just an abnormal surge of electricity in part of the brain. And so they work to regulate the electricity within the brain. So some of them will try to suppress excitation within the brain so that stop the electricity from revving up, almost like taking your foot off the gas when you're driving a car. Some will actually act to enhance the inhibition in your brain. So your brain has a natural mechanism to calm down abnormal electricity. So almost like putting on the brakes on your car to slow that down. And, some of them work in similar ways and some of them are quite different. Some medications work better for certain types of seizures. So some medications may work very well for focal seizures, but may actually make certain types of generalized seizures worse. So it's really important to understand what type of seizures and what type of epilepsy a person has when you're choosing the right treatments. Some types of medication are more what we call broad spectrum, so they can work for all different types of seizures. When we look at how people might be expected to respond to seizures, the good news is that the majority of people have seizures that will respond to medication. So about 2/3 of people will have their seizures controlled with medication. Sometimes it's not the first medication they try. They need to try one or two different ones, or sometimes even use different medications in combination.
Right.
But even in big studies over the years, we've seen that about half of people will have their seizures controlled even with the first medication that they try. So that's the good news. The unfortunate news is that about 1/3 of people who are left may have challenges in getting their seizures controlled with certain medications. And even if they try, 2, 3, 5, 10, 30, of the medications we have. And the really sad and frustrating things for those of us who treat people with epilepsy is that percentage hasn't changed from 50 years ago when we had 4 seizure medicines to now when we have over 30. There is still a group of patients with epilepsy who, unfortunately, their seizures just do not respond to medications. The other thing about that group of people is that we can usually identify them very early. It's there have been many studies done over the years looking at how to predict who's going to respond to medication, from back when we had 4 medicines to as recently as a couple of years ago. And as I mentioned, we can see that close to a half of people will respond to the first medication. Another 10 or 20% will respond to a second medication. And then after that is really diminishing returns. So once you've failed 2, 3, 4 medicines, it's really only about a 5 to 10% chance you will find the perfect medicine that's going to control your seizures. The important thing is that that's not zero, but it just means that it becomes more challenging with the first couple of trials. So the important thing is that we identify those people early. We don't have to wait for them to try 3, 5, 10, 30 medications to determine that they're not responding. We know very well that after they've failed 2 medications, it's less and less likely that their seizures are going to be under control. And we can get them into the pipeline for other treatments that may be appropriate for their epilepsy and may give them a better chance of becoming seizure-free, rather than having to go through 5, 10, 15 years of uncontrolled seizures and the impact that has on their lives.
As discouraging as it may be to feel like medication might not be an option for you, like there must be a sense of relief to know that earlier on, rather than trying so many medications with so many different side effects. I can't imagine how hard that is.
Yes, all medications, as we said, some of them work differently for different types of seizures. All of them have side effects.
Yeah.
And the side effects are different for each medicine. The key side effects tend to be brain type of side effects because these medicines are working on your brain. So they can have effects on things like concentration, energy, mood, can lead to people having symptoms like dizziness or unsteadiness or imbalance. But other medications may have different effects on the body as well, beyond their effects on the brain. And so those things are important to know about when choosing medications. There may be interactions with other medical conditions, and also there may be some very serious side effects that people need to be aware of.
I feel like the conversation around medication really speaks to how individual the epilepsy diagnosis process is, and how treatment should be treated just like that. You really have to figure out what works best for you, and it's not one size fits all. And speaking of that, I'm curious to know, when should someone consider surgery or other options and resources, and like who should you go to speak about that? Because I think the last thing you want to do is go on WebMD and try to sort it out yourself.
Yes, you're absolutely right. Dr. Google is our best friend and our worst enemy. So, absolutely, the real important message again is you don't have to live 10, 15, 20 years trying 30 different medicines before you can be a candidate for other treatments. Mm-hmm. Anyone who is living with epilepsy and has had their seizures not be controlled with 2 different medications should be referred for evaluation in a comprehensive epilepsy center. That's the place where you're best able to determine, first of all, do I actually have epilepsy, or is something else going on that's been misdiagnosed as epilepsy? Am I getting the right medicine even for my type of epilepsy? Because, as I said, some medications may be better than others for certain types of epilepsy, and some may actually make things worse. And then the third thing that a comprehensive epilepsy center can offer is an evaluation to see if you are a candidate for epilepsy surgery or other types of treatments for epilepsy beyond just trying more and more medication. One of the sad things that we see over and over again in our literature is that when people do finally come to epilepsy surgery centers and, go through epilepsy surgery procedures, they've already been living with uncontrolled epilepsy for 15 to 20 years. And that has such a huge impact on your life. And it's such a lost time, that really moving people forward early is key to trying to get seizures under control and being able to move your life forward.
What can you speak a little bit to the different kinds of surgery that people would be considering, and what does surgery really look like for somebody with epilepsy?
Sure. So there are lots of different types of surgery. When many people think about epilepsy surgery, and what's really the mainstay of epilepsy surgery is what we call resective epilepsy surgery. So what that means is, for a person who has focal epilepsy, we determine where the seizures come from in your brain, and then we see if it's possible to remove that abnormal area in your brain in hopes of controlling the seizures. That can be really the best option for seizure freedom or for a successful surgical outcome, but some people may not be candidates for a resective type of surgery. They may have seizures that come from more than one place in their brain. They may have seizures that come from a place in their brain that's what we call eloquence. So it controls a vital function like your speech or your control of your hand or your memory, for example. So you don't want to resect that. Or they may be people who actually have generalized epilepsy, so there isn't really one focal place that we can resect. Some of those people may be candidates for different types of surgery procedures. And one of the kind of newer technologies in epilepsy surgery is really what we call neuromodulation. And neuromodulation procedures involve different types of stimulation in either regions of the brain or in specific nerves to try and regulate seizures and control the frequency of seizures. These procedures are not necessarily as successful in terms of completely controlling seizures as a resection might be, but can still give a significant improvement in seizure frequency and seizure severity for a lot of individuals. Right now, we have 3 of these neuromodulation options available. The first to have been developed is what's called a vagus nerve stimulation, or a VNS device. And that is a device where a generator is placed in your chest, an electrical lead is attached to one of the main nerves in your neck called the vagus nerve, and the device is programmed and in an individualized way to send regular electrical signals back up to your brain to kind of modulate your brain's activity and can reduce significantly the frequency of people's seizures. One of the other features of that device is that it comes with a magnet, which when you swipe the magnet over the generator, it will activate the device and it may abort a seizure in process. So if someone's having a seizure, they may be able to stop a seizure while it's happening. And that piece of control, is something that's really attractive when it works, because one of the things about seizures is you don't have control, right? One of the newer developments with the vagus nerve stimulator as well is that the vagus nerve is a nerve that also goes to your heart. And we know that many seizures have effect on the heart, and particularly the heart rate. And the device can be programmed to detect changes in heart rate, and that may represent a seizure, and then deliver an additional stimulation to try to abort that seizure as well.
Is there any kind of treatments outside of medication and surgery that patients can seek? And I'm also curious, Dr. Bateman, if any of these newer treatments on the horizon you're particularly excited about.
So for outside of surgery and medication, for some people, they may be candidates for other types of therapies. One of the other big topics in treatment of epilepsy is diet therapies. And the big topic of conversation there is what's called the ketogenic diet. So the ketogenic diet is, everyone knows keto diet, you read about it on the internet, everyone's following it, especially here in LA.
Yeah.
So the ketogenic diet, when we're talking about use for epilepsy treatment, is bit more restrictive than what we think of in our general population as a ketogenic diet. It involves very rigid measuring of food intake and particular components of food, including carbohydrates, fats, and proteins. The diet has to be very rigidly maintained to maintain a specific chemical balance in the body to control seizures. It's often challenging for individuals to maintain, especially if, you have access to a cupboard and decide you want a cookie, because that can just completely blow the diet. Yeah. So people may have, be susceptible to having breakthrough seizures if they aren't very, very rigidly following the diet. And the diet does have some side effects over the long term. What people have also focused on, trying to work outside the parameters of such a rigid diet are other diets that are comparable in terms of having a higher focus on fats and proteins and lower carbohydrates, such as, the ketogenic diet that we're a little more familiar with, that are less rigidly controlled, or modified Atkins diet, low glycemic index diet. These kind of things have also shown some success in reducing risks of seizures in patients with epilepsy, though also sometimes hard to maintain.
As far as what to do when someone's having a seizure, basic seizure first aid, and then also, can you speak a little bit to rescue meds?
Yeah, so basic seizure first aid, step one, stay calm. If you see someone having a seizure, don't freak out, stay calm. Most seizures will end on their own within a minute or two. The person may be confused, disoriented, or sometimes even agitated afterwards. But most of the time, the seizures will end on their own. The main role for someone as an assistant to a person having a seizure is to keep them safe. So, and help protect them from injury. So if you're in the kitchen and your roommate, your family member has got a sharp knife and they're standing by the stove and they start to have a seizure, you get them away from the stove, turn the stove off, get the knife away, that kind of thing. If you can, if they're not already on the ground, help them get to the ground safely. If they've fallen and they're lying on their back or their front, you can turn them to their side. That's the safest position for them to be in to help them keep their breathing. And also, put something soft under their head, like a jacket or a cushion, loosen their collar. If it's someone that you don't know, you can check to see if they might have a medical alert bracelet or necklace about their condition, whether they do have epilepsy. So the other main thing is to One important thing to remember is to not do what that old wives' tale tells us, which is the patient's going to choke on their tongue or swallow their tongue. You got to put something in their mouth to stop them from doing that. The person is not going to swallow their tongue, but if you put something in their mouth, they might choke on that. They might break a tooth on it. If it's your finger, you might get hurt. And that really can cause more problems than benefits. If the patient is on their side, then that allows their airway to stay open and anything that might be in their mouth. So if they did bite their tongue and have a lot of blood or saliva, it will also fall out of their mouth as opposed to kind of being pulled back into their lungs.
Yeah.
After the seizure is over, can stay with the person, try to keep them calm. Do not try to hold them down or restrain them if they seem confused and want to kind of wander around. Just maybe don't let them wander off the balcony, for example. Again, keeping them safe. But as I mentioned before, some people may be quite confused or agitated after a seizure. And if you can imagine, if you were to wake up on the ground with a bunch of people standing over you trying to hold you down, what's your first instinct going to be?
Yeah.
Right? You're going to fight. So that's not great for the individual, and it's not great for the person trying to assist as well. If you can, try to time the seizure. Like I said, most seizures will be over within a minute or two, but any seizure that lasts more than 5 minutes, we consider that to be a medical emergency and what we call status epilepticus, which means that the seizures may be less likely to stop on their own and require medical intervention to treat them. Similarly, if you see them, they have a seizure, it seems to end, but then they have another seizure afterwards without coming back to kind of their normal self, then that's also potential indication of status epilepticus in an emergency. If the person has injured themselves in any way, if they stop breathing, that's also a 911 call.
Yeah. I would say too, the timing thing, it feels kind of like ridiculous to do it in the moment, but for me, it's really helped calm me down because I like have a fact that like I can look at and be like, no, I don't need to like call, because seizures are scary, like to see. And it kind of has helped me to like have a clock to focus on because there's not that much you can do for the person in the moment. And like knowing that it's not time to call 911 and that it's all, within the time frame. I don't know. I actually have found like quickly setting a timer on my phone and like seeing the countdown has kind of been like a monotonous thing to sort of keep my energy calm as someone assisting during that. So that is definitely something that I always think to recommend for sure.
And as you know, this podcast and also our foundation as a whole is really geared towards supporting young adults. And I'm curious to know how epilepsy on a biological level changes or affects, teenagers going through puberty.
That's a really important question. So there isn't necessarily a direct cause relationship between, puberty doesn't cause epilepsy, though there are certainly some types of epilepsy that may be more likely to begin when people are at that age where they may be going through puberty. And when we look at puberty just in general, of course, we all know it's a very crazy time. There's a lot going on. There's a lot of hormone changes and things like that. Your body's growing, your body's changing, you're trying to navigate society and your role as an evolving human. A lot of what we know about the kind of biological effects with puberty on epilepsy relates to women with epilepsy, and specifically women who go through hormonal cycles. So we can see some of those women have quite a tight link between their hormone cycles and their seizures. So something that we call catamenial epilepsy, which means that either the abundance of their seizures, the majority of their seizures, or even all of their seizures tend to happen at very specific points in their menstrual cycle. We also know that the seizures themselves can have an impact on hormone levels and the parts of the brain that control and release hormones. So it's not uncommon for women with epilepsy to have disruptions in their hormones. The seizure medications, at least many of them, can also affect hormones and how the body metabolizes hormones. So it becomes a bit of a vicious circle with, hormones impacting seizures, seizures impacting hormones, the treatment of seizures impacting all of those things. We see a similar situation in men, though we don't have similar hormone cycles that we see in women, but we can also see impacts of seizures in men on the levels of their hormones and impacts of the seizure medications on their hormones as well. There's a lot less study about, male hormones and triggers for seizures and that kind of thing compared to the circumstance in women. But we do know that there are effects both of the seizures themselves and the medications on hormones. And some of those may have effects on, long-term growth or development or things like fertility and those kinds of issues for both women and men.
Is it similar for individuals going through pregnancy and those who are transitioning, either trans men or women, how hormones relate to that?
Yeah, absolutely. So pregnancy is its own whole thing. We definitely see a lot of issues with pregnancy. First of all, many people focus on pregnancy and, these medications aren't safe. What do I have to stop my medications because the medication might harm the baby. That is absolutely what you don't want to do. We know that the effects of seizures during a pregnancy and the risks to both the baby and the mother from seizures are much higher than the risks of medications, though the medications aren't without risk. Certain medications may be safer than others, while certain medications may be much more concerning in terms of potential effects for a developing fetus. So it's important for anyone who's considering a pregnancy to speak with their neurologist, their epilepsy specialist about how to most safely plan their pregnancy and what kind of monitoring they may need during their pregnancy. Because the way your body handles seizure medications, depending on the medication, can change, and you may need to adjust your doses quite dramatically to keep yourself on the same level in terms of seizure control, and then subsequently change the doses again after the baby's born and your body kind of resets itself. So again, I would encourage anyone who's planning a pregnancy with epilepsy to really speak to their specialist about how to best manage that time frame. We know that some things reduce the risk of issues with a developing fetus. One of the mainstays of that is supplementation with what we call folic acid. It tends to be something that is in all women's prenatal supplements anyway, but can help to reduce risks for any kind of malformation in a developing baby. Again, the other thing is keeping an eye on seizure control and then discussion of safety issues after the fact. In general, it's safe to breastfeed babies when you're taking seizure medications, but also there are other considerations about how do I keep my baby safe if I have a seizure? How do I bathe my baby? Am I allowed to be at home alone with my baby? All these kinds of questions. In terms of transgender men and women, the considerations are still quite similar to cisgender men and women in terms of the impacts of both seizures and the seizure medications on hormones. So the other consideration is that hormones may impact certain seizure medications. So a person undergoing transition or taking hormone therapy may have to look quite closely at what their seizure medications are. There may need to be adjustments in their hormone therapy. If anyone is initiating hormone therapy, they also need to do that in conjunction, with their medical specialist for the hormone therapy, as well as their medical specialist for seizures, because some hormone treatments can actually lower the levels of certain seizure medications and put this person at risk for seizures. So there really has to be a joint work between treating physicians for that individual. Similar rule actually goes for hormonal birth control, by the way. Women who are taking hormonal birth control may have certain seizure medications that make it less effective, or starting or changing the hormonal birth control may also impact levels of certain seizure medications. Any provider who is treating a person with epilepsy has to take into consideration the whole person, not just the epilepsy. So you have to look at what other medical conditions they may have, what other treatments they may be undergoing. And that goes back to your earlier question about tailoring the treatment and the plan to each individual patient.
That makes a lot of sense. I actually didn't know how linked hormones and epilepsy were. I mean, it makes a lot of sense. Is there, I know you can develop epilepsy at any age. Is there an age where it's like most common to be first presenting?
Yeah, so epilepsy can start at any age, as you said. There are really two main peaks in when epilepsy starts. The first is in the very, very young, so under 1 year of age. The second peak comes in individuals as they get older, so sort of over 65 years old.
Oh, wow.
Obviously, the reasons for developing epilepsy across the lifespan can be quite different. So what causes a 2-month-old to develop epilepsy versus a 70-year-old to develop epilepsy are not going to be the same thing. But it is definitely one of the misconceptions about epilepsy that, well, I never had this when I was a baby, or no one in my family had this, so why do I have it? It's or I don't have a brain tumor, I don't have a stroke, why do I have it? I never had a brain injury. So understanding that epilepsy can impact anyone at any time, and again, like I said, 1 in 26 people over the course of their life is really an important message.
Well, I feel like our kind of last, Karan, correct me if I'm wrong on this sort of last wrap up question. We covered so much, and there's so much we
Yeah.
could go further in depth on, but I guess bringing it back to the young adults and epilepsy, could you sort of just give us are there any really specific concerns for epilepsy presentation and control during young adult years that you wish more people knew?
One of the real important things about controlling your epilepsy is understanding your epilepsy, understanding what things may be triggers for you for seizures. And some of those common ones would be being sleep deprived or overtired, being overstressed, using drugs and alcohol. And the most important one, skipping your medications or being lax with how you're taking your medications. So it is really important to kind of take control of things that are triggers for you, take your medications regularly, consider if you're having still seizures or you're having side effects from your medicines, don't just feel like you have to live with them. Talk to your neurologist, talk to your doctor about that, because we want you to be living with epilepsy well. We want you to have control of your seizures, but also not be stuck living with side effects from your medications. The other main issue for consideration, of course, is safety with seizures. And there are a few things that we talk about in that umbrella. Everyone always gets the message be careful about being at heights, be careful about swimming, don't use heavy machinery, be careful, you're not allowed to drive because you might have an accident. And all those things are important in terms of epilepsy safety and avoiding injuries and drowning. But there is also an increased risk of what's called sudden death or sudden unexpected death in epilepsy, SUDEP, which you guys may have spoken about before, in young people or any people actually living with epilepsy, particularly those whose seizures are not controlled, and particularly those who have generalized tonic-clonic seizures that aren't controlled. We know that how often you have those seizures is the biggest risk factor that we can control. So if you have, one generalized tonic-clonic seizure a year, it's a 5 times increased chance of SUDEP. If you have 3 of them, it's a 15 times increased chance. If you have generalized tonic-clonic seizures and you also live alone, the risk is increased over 60 times. So these are all factors that people have to consider again in how they live with and control their epilepsy. When we are teenagers, adolescents, young adults, of course, we're trying to transition towards independence. And one of the, things we really have to consider is how we, choose to live. Are we living alone? Are we living with roommates? Are we living with family? Are there things we can do to help improve our safety if our seizures are not controlled well? And then also just general planning of your life, rite of passage of adolescence is getting your driver's license. That may be something that's delayed or even not a possibility for someone with epilepsy if their seizures aren't well controlled. There may be different, educational challenges, which is something you can, again, discuss with your neurologist. You can get accommodations for school, extra time for your classes, extra time for your exams, this kind of thing. Certain career options may be not the best idea if you have epilepsy. But, when you're an adolescent and a young adult, you're really coming into the time where you have to start figuring out how you're going to manage your life.
Yeah, I feel like it really goes back to your idea of treating the whole person and
Right.
all of that. And I think obviously we have a suit up focus here at the foundation, and I think that's something that is important to understand as a part of epilepsy. Even though we're constantly trying to not frighten people at the same time, it's really important for people to know and be informed. So,
Dr. Bateman, thank you so much for joining us. And I know we keep saying this, Sophie, but I feel like I've learned so much, even though this is an epilepsy basics podcast and we literally are running an epilepsy foundation. I still feel like I've refreshed and specified my knowledge of epilepsy.
yeah.
We said that this is a basics episode, and we've also talked about how epilepsy is an individual's journey and should be treated as such. So make sure to do extra research and figure out what you need or your loved ones need. If you want to learn more, want resources, want to get connected to a support group, go to thecameronboysfoundation.org. If you want to join the conversation and also get connected with people, you can follow us on Instagram and Facebook at thecameronboysfoundation.org.
Also, Karan, don't forget, we must thank our sponsors, UCB, for making this possible. Thank you so much to UCB, and thank you, Dr. Bateman.
Thanks so much for joining us, and we'll see you soon.